Welcome to this series on revision surgery for videos. Today the topic is thyroid nodule part 1. A 28-year-old man complains of a swelling over the left side of his neck for the past 1 year. The questions to be answered at this stage: A. What further details of the chief complaint of the patient you want to obtain? And question B. What other symptoms will you ask for him for in this patient? Now, as you pause, answer the question, after which you resume the video to get the answers. The answers for this question A, the details of the chief complaint, will be the onset of the swelling, progression of the swelling from the time of onset, whether it's associated with pain, and also the nature of the swelling, single, solitary, diffuse, or multiple swelling, and whether the patient noticed that it moves with swallowing. The question B, answer to question B, what other symptoms you want to ask? In this patient, first is the pressure symptoms, hoarseness of voice, dysphagia, breathlessness, and stridor. And second group of symptoms will be whether the symptoms of hypo or hyperfunction of the thyroid gland. Next, we come to the physical examination and the questions related to that. C, question C. This is a picture of the patient's neck. Describe what you see on inspection in the neck of this patient. Question D. Describe how you will palpate the neck of this patient. And question E. What investigations will you do for the patient to help in the diagnosis? Okay, once again, please pause the video, answer the questions. After that, resume the video to know the answers. Okay, to the answers to this question. Question C. There is one large single nodule on the right lower end of the neck, lower third of the neck. It appears smooth, approximately about 3 by 3 centimeters in diameter, well demarcated, and we have to check whether it moves with swallowing. Next, the skin changes over the lump. There's no skin changes, a normal skin. And question D, how do you examine the patient? You examine the patient with the patient sitting on a chair in front, from the front, side, and back, and giving him a sips of water to check for the movement with swallowing. And whether it is tenderness, again you confirm the size of the lump and whether it is mobile. Answer to question E, what investigations you will do? You will do first a thyroid function test, which consists of T3, T4, and TSH. You also do an ultrasound scan and followed by an ultrasound guided fine needle aspiration cytology or FNAC. In this patient, if the chest X-ray may not be necessary at this stage, but in older patients, yes, we will do a chest X-ray. The FNAC done on this patient comes back with positive for papillary carcinoma of the thyroid. What is the subsequent management of this patient? Now please pause the video, answer the question, and then resume to see the answers. The subsequent management of this patient with papillary carcinoma thyroid is to do a CT scan to stage the disease. If it's possible, you may proceed with a radioiodine scan if it is available. Subsequently, you can proceed with a thyroidectomy as the definitive surgery for the papillary carcinoma. It can either be a lobectomy or a total thyroidectomy with lymph node clearance. It all depends on the staging of the papillary carcinoma. After the surgery, the patient is put on TSH suppression therapy, and also the thyroglobulin markers are done on regular follow-ups. What are the complications of total thyroidectomy? Now please pause the video as you answer the question, after which please resume to see the answers. The complications are mainly four. First, bleeding and hematoma in the immediate post-op period leading to tracheal compression and stridor. Recurrent laryngeal nerve injury leading to hoarseness and loss of voice. Injury to the parathyroid glands leading to temporary or permanent hypoparathyroidism, which result in hypocalcemia and tetany. And lastly is hypothyroidism induced by the total removal of the thyroid gland. Next, how do you examine this patient? So to examine the patient, you ask the patient to sit on a chair, and then you inspect and palpate the neck from the front, as shown in this patient, bilaterally on both sides of the neck. And again, palpation from the back with the patient sitting on a chair. Okay, so it's done by inspection and palpation from the front and palpation from the back to clearly demarcate and locate the thyroid swelling in the neck. Again, these slides show you inspection of the neck from the front, palpation of the thyroid mass from the back, and also looking for the location of the trachea, deviation for trachea. Okay, this is the picture showing you the solitary nodule in the right lobe of the thyroid gland. So the steps will be of inspection, the neck, ask the patient to swallow, palpate from the back, flex the neck slightly as you do so, palpate both lobes and the rest of the neck for lymph nodes. Additional tests may be necessary. General and peripheral signs and eye signs of thyrotoxicosis. Okay, this slide here shows you how the patient is examined from the back. Having said that, these are some of the important facts regarding solitary thyroid nodule. The solitary thyroid nodule is a palpably discrete swelling within an otherwise apparently normal thyroid gland. Usually it is a benign lesion, it's a thyroid adenoma, and in 50% of patients thought on basis of physical examination to have a solitary nodule have multiple nodules when studied by ultrasonography. In these cases, it is a nodule in a multinodular goiter. Solid or cystic. This can either be a solid or cystic, a solitary nodule. Cystic are usually benign. Solid adenomas can be malignant, and the risk of being malignant is less than 5%. Now I show you a short video on the examination of the thyroid gland.
Thyroid examination. Examination of the thyroid gland starts with inspection. In doing so, it's important to consider the gland's anatomy and its surrounding structures. The thyroid cartilage is a helpful landmark, since the thyroid can be palpated bilaterally below it. In healthy individuals, the thyroid only weighs around 18 to 25 grams and should not be visible. An enlarged thyroid, otherwise known as goiter, is considered class 2 if macroscopically visible. When the head is reclined, thyroid enlargement can be seen even earlier. Palpation is usually performed from behind, although anterior palpation is also feasible. The gland is often only detectable upon palpation if a pathology is present, such as nodules, enlargement, or an altered consistency. You should also note any tenderness to touch, as seen in inflammatory changes such as a viral infection. To assess the mobility of the thyroid gland, ask the patient to swallow, and offer a glass of water if necessary. If thyroid perfusion is increased, like in Graves' disease, examination may reveal an auscultable bruit and a palpable thrill.
Thank you for joining me for this short session. Hope to see you again in another session.